obtaining vascular access, the quickest and best way to do it is through a peripheral line, like a cubital fossa vein or an external jugular vein. These are very easy to hit. But on occasion, you need a higher volume of fluids, or you need something in place for a longer period of time, then you can leave an IV in place. Or sometimes peripheral access is not good, and so that leads to either an intraosseous access that we've talked about and that you'll practice over the next few days, or a central CVC. And central lines can usually occur in one of three places, either internal jugular, subclavian, or femoral. Most people don't do femoral lines anymore unless you absolutely have to because of the risk of DVT. So most central lines are placed in the subclavian, just under this clavicle, and that's what we're going to do today over in the lab. You'll see a lot of people doing IJs, but we're not going to mess with those. Okay, so start with a little bit of theory here. These are the objectives for today. The technique that we're going to be talking about today is what's called a Seldinger technique. And by the way, so I brought your ACLS cards down. This is a central line kit, and we have a bunch of these over in the lab that you'll use, and I'll go over this at the end. But let me quickly go through this slideshow here. Whoops. The indications for putting in a central line in. They're also, you may also hear this referred to as a triple lumen catheter, because the catheter that goes in the line, in the vein, has 3 ports. And so you may hear, somebody might say, to put a triple lumen in, or a central line, or a CVC, so they all mean the same thing. And the indications are here. The main ones I discussed, we're not going to talk about pulmonary angiography, we're going to talk about volume replacement and emergency situations. One of the reasons, a couple of reasons, you don't typically put central lines in a subclavian during cardiac arrest is you can't do it while you're doing chest compressions, and the tubing inside that goes inside the vein is really too long for giving boluses of meds like epinephrine or adenosine. Okay. Relative contraindications, there really are no contraindications. Relative contraindications to putting a central line in are listed here. Bleeding disorders or coagulopathies, patients who are fighting, you've got to stay still to do this because one of the primary complications of doing this, especially a subclavian line or an IG, is creating a pneumothorax. Obviously not with a femoral. The complication of a femoral is bowel, puncturing the bowel. But they all have benefits and complications. But in terms of a combative patient, you can't do this in somebody that's fighting you. Distorted local anatomy, meaning the venous structures, the anomaly is so different that as you're poking, trying to find that vein, it's not there. It's not where it's supposed to be. It doesn't happen with the femorals, but it does up in the subclavian region. And obviously, anything going on with the skin, you want to avoid sticking a needle through it. And that applies to putting a central line in, or tapping a knee, or putting an IO in. You just don't put a needle through compromised skin, period. Okay? Now, the best place to put a central line in the subclavian area is on the right side for a couple of reasons. One of them is the anatomy on the left side is different because you have the subclavian vein goes into the brachiocephalic vein, which then goes over to the superior vena cava, versus on the right side, you've got the subclavian, it just goes right into the, essentially the superior vena cava. So there are fewer twists and turns on the right than on the left. Also on the left, you have this thing called the heart. In case you happen to actually stick it all the way, the needle all the way through the vein, you don't want to be threading that catheter into the outside of the heart. So you'll see here in just a little bit. The technique, it uses an introducing needle to isolate or to locate the vein, the inside of the vein. And then you're going to use a wire. The wire is called a J-wire because when you pull it out of its sleeve, it has a hook on it. And that hook keeps the wire from poking through vessels, and it also allows the J-wire to go bouncing along the inside of vessels. Okay, so the J-wire, you'll hear somebody refer to the J-wire. That's what they're talking about. It's the guide wire. Then what you do is once you have the wire in place, you're going to thread things over the wire. So now you have the wire essentially serves as a passageway or conduit into the vein. And at the end, your triple lumen catheter goes over the wire. Once it's in the vein, you pull the wire out, and now you're good to go. That's basically it. The one thing I want to tell you is never, ever, ever let go of the wire, because you have the venous flow is headed that way. If you let go of the wire, there is a potential that the wire will get sucked into or drawn into the vasculature. A friend of mine up in Edmond, a guy came in complaining of chronic cough, a young guy, for no reason, chronic cough. He took a chest x-ray and he had a J-wire that was in his lung. Where would it be in his lung? Tell me where it would be in his lung. It was in the pulmonary artery. That's where he had this J-wire twisted up inside the pulmonary artery. That somebody, he'd been in a car wreck, and whoever put the central line in let go of the wire, and it got sucked in, and they never said anything about it. So yeah, it was crazy.
How long? I'm curious. How long did it stay here? Because you would wonder if you wouldn't have a clot that formed on that and went on. I mean, that just makes me shiver.
It was in there 3 or 4 months.
Lord,
It was in there that long. The guy had healed up from the car wreck.
Yeah.
But interesting, you know, because of interventional radiology now, all they did was go in, you know, and they were able to get it through a catheter. So, but nonetheless, you don't want a J-wire sitting in your pulmonary artery. So hold on to it. Yes, Samantha.
If the wire has a little J at the end, how do you pass stuff over that and pull it out without that getting caught?
It's very easy. I'll show you here in just a second. Just settle your butt down. So here, I'm going to show, here we go, right here. Okay, you stick the needle in after you've anesthetized the skin. And we'll go through the process this afternoon. You stick the needle in, and it's a pretty healthy sized needle. And then you see the wire up at the top there. The wire is threaded into the vein. And it doesn't show it on here, but it says flexible end. It flexes, it turns into a J. Once it goes through the needle, it'll curve on its own again. It's not like that. You straighten it out, and once it goes out of the needle, then it curves on itself. Is that what you were asking? No, anyway, okay, so you see on the panel C there, now that you've got the wire in, you withdraw the needle. Once you withdraw the needle, now you're just holding onto this metal wire sticking out of somebody's chest. You have to enlarge the hole in the skin and in the through the subcutaneous tissues and the vein in order to get this great big catheter over it. So you take a number 11 scalpel blade, you just stab the skin, you make a small hole in the skin, and then you take a thing called a dilator, which is where it says sheath, oh, it says dilator there. You run that through there, and you twist it like that, and that creates a bigger hole through the process. Pull the dilator out, and now you thread your triple lumen on top of it. And once you get the triple lumen in, now you pull the wire out, and you're good to go. Okay?
Are you doing this via ultrasound or just?
No. Well, two things. You can put central lines in without ultrasound. That's fine. The ultrasound guided insertion is becoming the standard of care. So on Thursday, we're going to have ultrasound over there. You can find the subclavians and find the internal jugulars, the femoral veins on each other. But if you have an ultrasound there at the bedside, you can certainly use it, but you don't have to use it to put it in. Okay? But it is becoming, especially in larger markets like Oklahoma City, it really is the standard of care. But you get out, Blackwell, I'm sure
They have a fast.
they have a fast, now, do they do ultrasound guided central
I
lines?
would assume they would if they've got the fast ultrasound. There would be no reason not to, because if you were.
No, you're talking about Jeff Shewart, so there's a reason,
You
so.
better cover your butt. Why would you use it? I
Um,
don't use it. If
you're
you have
gonna-
access to it, I use it.
You don't have to use it. And matter of fact, these things were put in probably 30 years before anybody
Right.
decided, oh, wait a minute, we can use an ultrasound. Now, the ultrasound is just there to find the vein.
Right.
Once you find the vein, you don't need the ultrasound anymore.
Because the one time I saw it done just a couple of weeks ago, they did it was like a magnet thing they put on the chest, and the J-wire had a little magnet in it. So they ultrasounded to find the vein and then stuck it, and then once they threaded the J-wire through, they could see it curve. It was really cool. You could see it curve around to the chest.
A magnet
Where do they
thing.
use the
It was like a thing they put on the chest. The J-wire has a magnet in it, so it just detected the wire and where it was, so you could tell where.
Oh,
It was
okay.
watching.
It wasn't fluoroscopy. It
No.
was yeah,
It was
okay.
just like a
Okay.
magnet thing.
Well, we're not going to be using magnetized J-wire. We're going old school here. So, now, pre-catheter prep, you have to, the 3 lines are full of air. You have to fill those with saline before you start injecting in them, right? That makes sense. You don't want to give somebody a pulmonary embolus. Post-catheter placement, once you get it in, you need to make sure that each line works. So you need to be able to draw blood from each one and inject it back into the patient and flush it out. You secure the catheter with sutures as a way to do that. If we have time, actually you can do a YouTube video on suturing a central line catheter in place. There are a couple of different little tricks to do that. We won't be able to suture on the model over there, but actually when we have the cadavers the next 3 days, if you put the triple lumen in, you can practice suturing it in place then. If you need help, I'll be glad to help you. Tegaderm is a little sticky plastic, thin membrane. You just put over the site where it's entering the skin and where you sutured it down, just to protect it. You always want to get an X-ray to make sure that the catheter tip is sitting in the superior vena cava. It cannot be in the atrium and it cannot be in the ventricle. It's got to be in the superior vena cava. Okay? And then, of course, you're going to do a procedure note from your activities here. So, basic principles here. Decide if the line is really necessary. A lot of people put these things in, and they're really not necessary for several reasons. One is because it's a fancy procedure, and you get to bill like crazy for it, but it's not really necessary. During cardiac arrest, if you're not getting them back, there's really no need to put a central line in, although a lot of people will because of the practice of doing it. So there are a lot of unethical uses for central lines. Use a central line for the indications that I gave you before. You got to know the anatomy because you're playing with a kind of a small area here, and there are some big things that you don't want to hit with that needle, like the brachial plexus and the subclavian artery and the parietal pleura. You want to stay away from those. The other thing about the X-ray here, taking chest X-ray, not only is you're doing the x-ray for the catheter tip, you're doing it to confirm there's no pneumothorax. Okay. The equipment, know these trays. These trays, this is a very common with the Arrow brand, but there are 50 billion different types of these trays. And you need to familiarize yourself before you start using this thing. Take your time. This is a sterile procedure. And so one of the things you're going to do today is learn how to put on gloves in a sterile manner. You would also have typically have an operatory gown on, and this is all sterile with a mask, eye protection, a bonnet, the whole thing, unless you're in the emergency room and access is critical. You don't have time for all that. But at a minimum, you want to use sterile gloves, because once you open this packet here, the inside of this is sterile, okay? So that's sterile, all right? If you run into trouble, if you don't aspirate blood, if you aspirate air, that means you're in the pleural cavity and you need to find somebody to help you out. Okay. Any questions about that? All right, let's go. There's some advantages and disadvantages of an IJ or subclavian or femoral are here. 90% of the time, you're going to be dealing with subclavians. In the ICU and in the ER, you're dealing with subclavians. When you start dealing with chemotherapy drugs, that's when they do a lot of IJs. But and again, most people just don't do femorals anymore. Now, if a lot is going on and you're running a code, if somebody's running a code and you can't get vascular access, you don't have an IO needle, and they're doing compressions up here, don't hesitate to grab a kit and do a femoral line in that instance. You've got to get access, so that's a way to do it there. Okay. Surface anatomy. So the thing about this is you want to remember is that the subclavian vein and artery exit the chest through the superior aperture here and go up under the clavicle and over the first rib. So over here they've taken the clavicle off, so you'll find the subclavians over the first rib. The good news for us is that the subclavian vein is the first thing you get to. The subclavian artery is deeper, and in behind the subclavian artery, you'll find the brachial plexus. So nerve injury is one complication of the central line, the subclavian line, but if you hit a brachial plexus, you don't know what the hell you're doing, and you shouldn't have done it in the first place, okay? Positioning, the right side is preferred, you know, you put them in what's called Trendelenburg position, which is the head down, just a few degrees, and that will increase venous congestion and dilate your subclavian as much as possible. You want the shoulders essentially neutral with the head neutral. You don't have to put the head like this, just put the head neutral. Some people will like to abduct the arm, and that decreases the deltoid mass and kind of opens up this area a little bit. But you'll see that unless you've got a bulky person, you really don't have to do that. The arm can be just down. Okay? Needle placement is important here. It is the junction of the medial third of the clavicle with the middle third. That point is where you want to go with the needle. Now it's going to be quite obvious on this mannequin over there because there are puncture holes there. But you need to feel it on somebody else that, she's got a lower shirt. So so feel out the clavicle. There's the length of the clavicle from there to there. So it's the middle third, the medial third with the middle third. So that point right there is where you want to go with the needle. Okay? And if you feel right there, there's a little tiny tubercle. That's where the clavicle makes its bend, right there, and you can feel it, okay? The needle, as it goes in, should be parallel to the skin. It's not, some people say up 5 degrees or so, but parallel to the skin. If that's the clavicle, you want to go right under it, okay? And a lot of people will hit the clavicle and put a little lidocaine right there to anesthetize the clavicle, the periosteum of the clavicle, before they start running that dilator and the triple lumen through there, okay? Now, when you do this, as you'll see, when you do this, you're standing to the patient's side, okay? So I've identified my spot is right there. I'm going to put my thumb on that spot, and I'm going to put my index finger. Can you slide that around? Mm-hmm. I'm going to put my index finger in her jugular notch, right there. When I take that needle, it's going to be parallel to her skin. I'm going to point it and drive it right towards the tip of my finger that's in the jugular notch. Don't do it that way, because that's going to go into the triangle and you're going to start hitting big things. Go towards the tip of your index finger that's sitting in the jugular notch. If you take your finger out of the jugular notch, whoever's supervising you will rap you on the head. Keep your finger in the jugular notch as you're moving this. Okay? All right. That's a description of what it looks like. Actually, that's not quite good enough, because you see that's pointing more towards this way and not towards this way. So if I were to redraw that picture, I would move the needle or the syringe so it was headed towards the jugular notch. This one is more accurate right here. It's going right to that person's fingertip. You're going to be impressed at how shallow that subclavian is when we get over there, okay? Complications, air embolus. If you stick the needle in there and you take, so you got the needle in there, now you take the syringe off that you would pull it back, you know, you got a flash, that's how you know you're in the vein. You pull the needle off, well now you have air going, you know, you have an open conduit into the vein. Well, it's going to suck air in there. If you don't put your thumb over the hub of the needle, you're going to wind up with an air embolus. So that's not a good thing. Puncture, hematoma, blood clot, sepsis. There's a lot of crap that goes wrong here. Dysrhythmias, if you take the tip of that catheter and you start threading it in there and you're bouncing off the ventricle, there's this little thing called fibrillation you can get into that's not really good. Pneumothorax, by far, is the #1 complication. Thoracic duct injury. What would happen? How would you get a thoracic duct injury? Because you put it in the left side. Why would you put a central line in the left side?
Couldn't access the right?
Because the left side is already messed up. If you have a gunshot wound to the left side and collapse the lung, why would you put a central line in the right side and run the risk of collapsing the right lung? Put it in the left side. What was that?
The only lung that's left is
Yeah.
increasing the risk.
Yeah, don't mess up the only lung that's left. Okay? That's the only time you put it in the left side is if the left side's jacked up. This is an ultrasound guided that you'll see. This is actually an IJ. If you want to practice putting an IJ in, then do a YouTube IJ insertion, and they'll show you the landmarks. It's essentially the top of the triangle between the sternocleidomastoid and where you can see on the video. There's the edge of the sternocleidomastoid right there. So there's a triangle right there coming down from the anterior viscera. That's the top of that triangle is where you're going to find the internal jugular vein, and right behind it, though, is the carotid. So carotid perforation is a risk for IJs. If you actually come down a little lower like this person is doing, you run a better chance of hitting the IJ and avoiding the common carotid. One of the things that you know that you're in the vein on ultrasound is veins are compressible. So if you have, when you do your ultrasound on Thursday, you're going to have two vessels. One's the carotid, one's the internal jugular. When you push down on the skin, the vein will collapse like that. It's compressible. The artery does not compress. That's how you know which one's which on an ultrasound. Oh, here this is what they look like, and then if you compress them, you'll see that it compresses like there. This is the femoral vein that they're showing here, and so you can get each other's femoral veins. When you remember the anatomy, the nerve is on the outside, right? Nerve, artery. So if that's the artery right there, the nerve should be right here. You can actually see a bright circle. That would be the femoral nerve when you're checking out each other on Thursday. This is the inside of the kit. We'll play with it here in just a second. Here are some, this is the proper positioning of the subclavian line right here. The proper positioning. So you can see there's the line right there coming in, going under the clavicle over the rib, and you can see it coming down, and there's the tip right there. So it's in the proper place. It's in the proper place. This is another one, but this is not a subclavian. This would be an IJ because it's going up over the clavicle. You see that up and over and down right there. And if you draw the line, this would be an internal jugular SVC, which is depicted here. And this one right here, you'll see this is another internal jugular. You can see it passes all the way down. Too far is where it is the problem with this one. It's too far. It needs to be pulled back. This one right here came in. This is a subclavian, but instead of turning to go down to the superior vena cava, it went up the left brachiocephalic and is going up into the left side vasculature here. That is way malpositioned. You can also note in this tape, X-ray here, there's the radio-opaque stripe of the endotracheal tube, and this person actually has, you see that line coming down right there, they're going to have an NG tube down as well. So you can see it going up that way. This is one that came in, this is a subclavian that came in and went up the internal jugular. So the little darn things, you got to track them down here. So that's not right position. Okay, so that's it. So what I want to do now is I want to show you a quick video.
Is there any way for you to tell, like, when you're placing it?
If it's going in the right place or wrong place?
Can you see it?
No, not really.
That's where that machine that JC was talking about, having the magnetic wire and watching the tracking, it's a new technique, but not every place is going to have that available. That would be a way, because essentially if you saw it tracking the wrong direction, you just pull it back and then feed it again and see if it would change direction. PICC lines, they do that a lot with as well.
I have a question. I know just when I saw the one, they measured like a distance. Do you measure to ensure that because wouldn't that be a way you could tell, oh, I'm not in the right spot because I'm not at the length that or even around the length that I measured?
15 centimeters is kind of what you're looking for.
Okay.
And the wire has a marker on it, kind of like an endotracheal tube.
said something last time they had to change it in the box.
What'd you say?
Amber said something last time they had to change setting up.
This isn't posted, right? The power. Okay.
Hey, here's the thing.
That one. Cervical ribs. I don't know where they are. You did that. You got I swear.
I know, it's like this big. I'm like, be like,
They're the good ones, like the free ones. Like the ones that you buy out, like so, like stiff. I have nice ones. Yeah, I like that. I'm gonna go to the Albertsons. He knows, he's so stressed. Yeah, let me go.
Like our own.
I just like that. I don't know. Style. I don't like